Hello and welcome to our training today as part of our Understanding Schizophrenia Spectrum Disorder series. In today's discussion, we'll be talking about the APA's guidelines for treatment and how that intersects for care. Just a note, this presentation has not been reviewed by APA and doesn't necessarily reflect the official opinion of that organization, but today's discussion is we're helping people understand how to apply those guidelines into the care process. Let's take a look at the objectives for today. The goal is that by the end of the session, you'll be more familiar with the APA guidelines and some of those details within those guidelines, and then understand how components of the care process in which APA guidelines can be applied. Let's look at our two major sections for today's discussion. First, we will have an overview of those guidelines and discuss the principles and how and specific recommendations within those. And then, like I said, applying the APA guidelines to care and looking at a specific case study and how that could work. So I am pleased to be joined today by three accomplished speakers that are really passionate about providing the right type of care and helping us better understand how we can do that. So first we have Dr. Kate Warburton, who is the statewide medical director for the California Department of State Hospitals, and she is also an associate professor at the volunteer clinical faculty within the UC Davis Division of Psychiatry and Law. We're also joined by Dr. Mark Avery from Health Management Associates, who is a board-certified psychiatrist and a recognized leader in the subject of person-centered care. We're also joined by Dr. Deborah Rose with Health Management Associates, who is a New York State licensed clinical psychologist and is passionate about assisted outpatient treatment programs and making sure that they're person-centered, evidence-based, and can support people in their recovery. So I'm pleased to turn the time over to Dr. Warburton to get us started.
Thank you, Patricia, and welcome to our training session on applying the APA guidelines for diagnosing and treating schizophrenia. In this section, we will first discuss the American Psychiatric Association's evidence-based practices and protocols designed to enhance clinical accuracy and improve patient outcomes. Then we will look at how these various recommendations and considerations can be incorporated into the care process, with consideration being given to the outpatient nature of care and the specific needs of the care population. Our goal is to equip you with the essential knowledge and skills needed to ensure that we are using evidence-based practices to meet the unique needs of these individuals. Because the rather unique aspects of schizophrenia spectrum and other psychotic disorders, it's not a one-size-fits-all approach. Rather, it will take applying these best practices with flexibility and taking a trauma-informed approach. In the next couple of sections, my HMA colleagues, Dr. Mark Avery and Dr. Deborah Rose, will provide information about these best practices and how they apply to care. Now I'd like to turn it over to my colleague, Dr. Avery.
Thank you, Dr. Warburton, and thanks everybody for joining this presentation today to cover this important subject. I'd like to start off with the first part of this training to talk about an overview of the American Psychiatric Association guidelines for treating schizophrenia. So these guidelines have been in development for well over 20 years now. They're developed, as mentioned, by the American Psychiatric Association, a leading national behavioral health organization who has really helped out over the last 20 years in many ways, but one of the ways is in creating these guidelines. The guidelines are generally developed by in a multi-pronged way, with first identifying key clinical questions that need to be addressed setting up work groups and getting feedback from distinguished people, clinicians, and other folks all across the country, looking at the research. And then when high quality research was needed, they also provide some support, oversight, and even funding for some of that research as well. These guidelines have gone through several editions over the years, and they're updated fairly regularly according to literature, as the literature and as the general standard of practice changes. The last version was updated in 2020, and in those guidelines, they've now divided it up into 3 buckets that we're going to discuss in the next slide. But first, taking a step back, they also used several key principles in developing these guidelines. The first is probably first and foremost, is the APA guidelines start with the use of evidence-based interventions whenever possible. But what does that word evidence-based mean? The term actually refers to those interventions that have been identified through rigorous studies to verify that they are effective. Many of those recommendations in the guidelines, and especially for medications, are graded according to the available evidence. So some evidence is stronger than other evidence. And again, these guidelines are periodically updated with the strength of evidence as more developments come in. But there's also other key principles that the APA has really focused on in developing these guidelines. The next is to take a person-centered approach, where every recommendation is in the context of a person-centered care plan. And of course, a person-centered approach means taking a humanistic approach to care. Part of that includes taking a recovery focus and embracing the principles of recovery as an approach to care. The Substance Abuse and Mental Health Services Administration has a definition of recovery as supporting the process of change that promotes the individual's health, wellness, and ability to live a self-directed life, and this is viewed in a longitudinal way. Of course, none of this happens in a vacuum. Persons with any condition, have communities, have family, have other elements of their lives that we want to consider. And so another principle is fostering family support whenever possible in providing care to persons with schizophrenia. Ultimately, all of this works off an integrated treatment team and integrated treatment plan that everybody works off of. And also the APA understands that these treatment guidelines aren't a one-time deal, that treatment of schizophrenia, like many conditions, requires regular support, follow-up, and monitoring. In the notes there and at the bottom of the slide, there are additional links where you can look up more research about these principles of the APA guidelines. But let's move to the next slide. So as I mentioned before, the APA guidelines are divided up into 3 main categories or buckets of work. The first is starting with an assessment and determination of a treatment plan, and I might say starting with a comprehensive assessment. The second bucket that they look at when considering treatment recommendations are pharmacotherapy, and anything that's not related to medications or physical treatments. It falls into what the APA views in the third bucket as psychosocial interventions. Before I move on a little bit, let's think about a little bit about what is a guideline and how does the APA view them. The goal of these guidelines is to improve the quality of care and treatment outcomes for as many persons as possible, and to bring the evidence into a translation, as it were, for persons and care providers in the field that want to make best use of the available evidence at the time. But following these guidelines doesn't guarantee success for everybody, and it's important to realize that these really are guidelines. They're not laws. They're not requirements. They're guidelines. So a clinician or somebody receiving services would use these as guideposts to help fit in and create a treatment program for themselves that makes most sense for themselves as a person. Okay, let's go to the first bucket on the left-hand side, assessment and determination of a care plan. I also want to challenge you as we go through these different slides is to be thinking in the back of your mind, perhaps, how does this stuff that we're covering here, how does this apply to the Care Act process? This, in the second half of the talk, we'll cover that more explicitly, but I just want to challenge you to be thinking of that as we go through this. Okay, so the assessment and determination of a treatment plan itself has a few parts to it. And the first is the thorough assessment. So you can't get anywhere if you don't know where you're starting, and it is very important that persons with all behavioral health conditions, and especially a complex condition like schizophrenia, starts with a complex psychosocial assessment that includes behavioral health information, psychosocial information, medical information, substance use information, community housing information, vocational information, and other sources of information. So understanding the person fully at the outset is very important. The APA has also recently incorporated a second principle for treating persons with chronic conditions like schizophrenia, and that's to challenge ourselves to always include some sort of quantitative measurement at the outset and in an ongoing way. Why did the APA add this second part of quantitative measurement? Part of it is because in previous years, we've maybe not been so good at that, not so good at saying, okay, this is what the person was challenged with. These are the symptoms that the person had 6 months ago. How are they now? Where do we want to get to? What's our goal at the end of the day? How will we measure that? How will we know when we get there? In mental health and behavioral health, we don't really have lab tests like they have in physical medicine. So we have to devise our own mechanisms for measurement. Sometimes that includes, a standardized tool like a psychosis rating scale or something like that. But sometimes this needs to be generated on the fly because, again, we're working with individuals and unique persons. But what other method the clinician and the consumer take, you should take some time to take pause and say, how are we going to know when we get there? How are we going to measure that? And then finally, you take this measurement part of the measurement strategy plus the comprehensive assessment plus your interactions and dynamic interchange with the person and their chosen supporters and family members to create a documented, comprehensive, and person-centered treatment plan. A tall order to accomplish all of these things, but clearly each of these steps is very important in our goal to achieve the outcomes that we're looking for. Okay, that's part one of those three buckets. Let's move on to the next bucket, which is pharmacotherapy. So pharmacotherapy refers to the use of psychiatric medication for the treatment of schizophrenia and related conditions. So how can we understand the pharmacotherapy guidelines? First, starting really at the very high level, psychiatric medications are generally clumped into different classes. and each of these classes is used for a different purpose. The class of medications that are generally used to treat the psychotic symptoms of schizophrenia are called antipsychotic medications. And really, there's a number of them out there, well over a dozen of them. And it's not really incumbent on courts and counsel, for instance, to know all these medications and recommendations by heart, and which one is better, which one has different side effects. However, the courts can play a pivotal role in ensuring that the prescribing system, the behavioral health providers or whatnot, are carefully considering and calibrating medications to meet the needs and goals of the individual care participant. So, for instance, if the person doesn't seem to be doing very well lately, has an adjustment in medication been considered? The APA guidelines make suggestions for prescribing and monitoring individuals with antipsychotics, while also monitoring for effectiveness and side effects, and continuing those treatments even when the symptoms have improved, and ideally treated with the same antipsychotic that made that person improve. So medications aren't a one-time thing in this condition. Generally, medications for schizophrenia are used over time. And it's also important and highlighted in the APA guidelines that the clinical team work to address any side effects that are associated with antipsychotic therapy, such as involuntary muscle contractions. There are a side effect syndrome that leads to a kind of Parkinsonism-like effect. They can have a side effect of slowed movements, stiffness and tremor, or even a movement disorder such as tardive dyskinesia. All these things are very important side effects that need to be monitored and addressed in the individual for obvious reasons. Let's move to the next slide. Antipsychotic medications are an important component in offering persons relief from their symptoms and making it possible for them to make gains in other aspects of their recovery. A person with schizophrenia spectrum or other psychotic disorder may be prescribed various types of psychiatric medications, and it can oftentimes be confusing to the outside viewer about, why are there multiple medications being used? What's the purpose and benefit of each one? The main goal of antipsychotic medication, as I mentioned, is to both reduce the active symptoms and to maintain remission from psychosis, and therefore they are typically required over time and maintained over time, even once those symptoms are in better control. And generally, antipsychotic medications require ongoing monitoring by someone who specializes in psychiatric medication prescribing, because people may react to medications very differently. And dosage oftentimes needs to be adjusted, and it's fairly common that medications need to be switched from one to another in the same individual. And so this doesn't necessarily mean that there was a failure in the strategy or the treatment per se for an individual, but just that in any one person, dosage, as I mentioned, needs to be adjusted over time. And it's important to know that antipsychotic medications may be effective in any individual. Antipsychotics may be effective for some, but not all of the person's psychotic symptoms. And as I mentioned before, it comes with the potential of having side effects. Let's move to the next slide to talk about one type of antipsychotic medication that is used in a specific situation. And these medications are the long-acting injectable antipsychotics. So almost all of the antipsychotic medications come in an oral or pill form that the person takes on a daily basis. And typically, the oral or pill form is how a person starts on an antipsychotic medication. But there also are available long-acting injectable antipsychotic medications. These medications, once a person is stabilized on them, are administered once every from 2 weeks up to 6 months now, but they are done through an injection. And these are different, by the way, from other. There are short-term injectable antipsychotic medications that are sometimes used in emergency circumstances, but we're not really talking about those. We're talking about these long-acting ones here. These long-acting injectable medications can reduce the need to remember to take medication every day, and they can be convenient in other ways too. You don't have to carry the pills around with you wherever you go and that sort of thing. Some patients find this to be more convenient and may improve medication adherence. Long-acting antipsychotics have been shown to be effective in preventing relapse and rehospitalization. And it's because of how these medications work. They have a very slow release in the body, and therefore they're available to provide a therapeutic effect over a long period of time. And they actually cut down on the risk of abrupt loss of effectiveness due to starting and stopping a medication too quickly. So, as you might guess, the APA guidelines suggest that a patient receive treatment with long-acting antipsychotic medications if the person prefers such treatment, or if the person has a history of difficulty or adhering to an oral medication. Okay, let's move to the next slide, because as I mentioned, often people with experiencing schizophrenia oftentimes are prescribed other medications, and it can be kind of confusing. Why is this one person receiving multiple medications? Well, first off, of course, people with schizophrenia also could potentially have medical conditions, blood pressure, diabetes, high cholesterol, and they may be receiving medications for that. But an individual living with schizophrenia also is sometimes prescribed other psychiatric medications as well. And this is often done to provide relief to those other psychiatric conditions that the person might experience. And this includes things like depression, bipolar disorder, or other conditions that may be separate, though usually related to the schizophrenia itself. Also, other medications are sometimes used to treat a symptom of schizophrenia that the antipsychotic didn't help with in that particular person, for instance, such as insomnia. And there also are medications that are available that are used to treat the side effects of antipsychotic medications. So it's also possible that a person might be prescribed medication for that purpose. Okay, that's a lot about medications. With that, I'd like to move to the next slide and pass the mic to my colleague, Dr. Deborah Rose, who will walk us through the psychosocial interventions.
Thanks, Dr. Avery, and thank you, Dr. Warburton. It's good to be here with both of you today. We've talked a lot about APA guidelines, 2 of them. Let's jump forward to the 3rd guideline about psychosocial interventions. Really important to remember that these are services that are tailored to people at different points of each person's recovery. So there may be some that are working and effective now, not so good later. different services for other people that are really best practice approaches. I'm not going to read them all to you. There's a list on your screen, and you could take time to read them all and get more information at your leisure. I'm going to highlight a few that I think are noteworthy, beginning with the coordinated specialty service programs or specialty care programs. Dr. Avery talked about evidence-based programs. You might hear me say EBPs. These are really proven effective interventions. And in this case, the coordinated specialty programs that are most noteworthy are those for people who are experiencing a first episode of psychosis. And so these are very intense, comprehensive services by a multidisciplinary group: physician, psychiatrist, nurse, social worker, psychologist, peers, and they're designed to do some support early intervention in people who are experiencing first episode of psychosis. Psychoeducation, exactly what it sounds like, providing information to people, and really it's designed to help people understand their illness, their recovery, their strengths, and to be better informed of what decisions that individuals can make. Supportive employment programs. These are opportunities to help individuals in their recovery seek and maintain competitive employment. So it's about helping somebody with job skills. It may mean providing on-site supports or collaborating with a boss or a company to ensure that a person's needs are addressed while that individual is able to maintain recovery and maintain a job. Super important. APA talks about it. We're going to talk about it. Family interventions. It's really essential to involve family, natural supports, chosen supports, and to help provide information and education to family, to provide support to family. So this isn't about looking back at what's happened, but about looking forward and what kind of planning might be involved and how families can become educated, can serve as advocates, and be supports and be supported in an individual's recovery. Self-management skills are really about helping somebody to learn how to manage their own lives, their own symptoms, their own treatment decisions. It's really about helping to prevent relapse, to mitigate relapse, recognizing early signs if other kinds of recovery supports, changes in treatment, changes in medication may be warranted, and really to develop a relapse prevention plan. Here's how I see myself being helped, what's been effective, where I can go so I can continue to thrive in recovery. I'll talk about one more. I'm just going to mention it here because I'm going to talk about it a great deal in a moment, which is an assertive community treatment team. An assertive community treatment team is like a clinic on wheels in the community, and it's really for folks who maybe haven't engaged in traditional forms of recovery. So hold on to that thought, and we're going to have a slide. The next slide actually will be about assertive community treatments and also what they look like in California. A couple of quick notes before we move forward is that although APA doesn't specifically talk about housing, when we talk about CARE or CARE Act in this context, we do think it's important to recognize that housing, supportive housing in particular, can be an effective and should be included in somebody's recovery plan. So there's some information, and there's a link at the bottom of your screen if you want to learn more information. But why don't we move forward and let's talk about assertive community treatment. Okay, as I mentioned, assertive community treatment, often referred to as an ACT team, is another evidence-based program that is designed for folks who maybe haven't historically engaged in traditional treatment. So these are for people who maybe aren't coming into a clinic or into a hospital setting to receive care. So it's a community-based service like a clinic on wheels. It's a comprehensive program that is offered by a multidisciplinary team of professionals: psychiatrist, a nurse or nurse practitioner, a peer, a social worker, maybe a benefits coordinator. Often includes a family specialist or a job voc education professional. Services can be provided 24/7. Most services are, of course, occurring on weekdays and weekends during traditional business hours, but services are available at after hours for routine care and for an emergency response. Really, an ACT team, which again is this SAMHSA recognized EBP model, is based on high touches by multiple members of the ACT team. So somebody might meet with 3, 4, 5 treatment team members at least 6 or 7 times in the community. And in the community, meaning that somebody could be living in a private home. They could be unhoused, street homeless, or in a shelter. So the treatment team comes to the individual and supports that person, regardless of where they're living and where they're at in their own recovery. Lots and lots of evidence says that ACT team supports individuals to reach recovery, to prevent relapse, and to have reduced recidivism. So I did mention that ACT is a standardized evidence-based practice. There are also very similar teams called FSPs, Full Service Partnerships, in California. They are also designed to be in the community, perhaps not quite as high touch as the ACT team, but a very similar model. So if you'd like to learn more about ACT or sort of community treatment, there's a link at the bottom of your screen, and they will be available in the notes as well. We often like to stop and pause, and I will invite Dr. Avery to come back and join me when we think a little bit about how the APA guidelines might apply to people who are in care. So, Dr. Avery, any thoughts that you'd like to share with the group?
Sure. Well, we've got a few ideas here already printed out for you on the slide to consider. And I was thinking, Deborah, as you were describing the assertive community treatment model, that it utilizes a multidisciplinary team approach that generally has a wraparound approach to the patient. And by that, we mean the services wrap around the patient or consumer with the idea that we do our best to address all of the person's needs and avoid the person falling between the cracks. So that's ACT. But if you think about it, really, most people with schizophrenia require a team approach to care and a team approach with different people representing different disciplines. So everybody should have a multidisciplinary team, and that team should be endeavoring to work cohesively to provide this same wraparound approach, whether or not the person is in an ACT team or not.
I think that's a really great point.
The other thing I would like to challenge folks with is the idea of how do these psychosocial who decides? How do we decide on psychosocial? How do we create that care plan? And the idea is, the best way to develop that is in a smooth and open partnership between the recipient of care and the people who are delivering that care. So there's a concept and this includes medication decisions. And so, there's this concept called shared decision making in which, that in this fruitful partnership, the care the patient or recipient of care brings in their personal experience, their own concerns, their own goals. The care provider brings in their professional knowledge of what works and what doesn't work in the context that we're talking about. And then in that partnership, that's how this customized individual care plan gets developed. And I already said that. So bouncing all the way back up to that first point is that really applies as well with medications. That the approach to medication and all interventions really need to be individualized person by person. What do you think, Deborah?
All great points. Much appreciated. I say we continue and move forward. I think we're going to have some time to bounce around a couple of ideas with each other shortly. So let's take a moment and think about how APA guidelines for the treatment of individuals with schizophrenia impact or are aligned with care. Next slide, please. We often like to use an exemplar. This is a made-up individual who may look familiar to you, some of the individuals that we've worked with over time. Again, not a real person, but we're going to think about the APA guidelines and about the alignment with the CARE Act through the lens of George, our example. George is an adult who was diagnosed with schizophrenia in his late 20s. A couple of other diagnoses earlier on in his 20s, finally landed with a treatment team who identified schizophrenia. George has a history of non-adherence with meds. He at some point had been taking them, but he didn't like the side effects and he stopped. Important consideration for why maybe he wasn't adherence with the initial treatment plan. George has some co-occurring medical conditions, and he also has a history of using substances and alcohol. A couple of factors that are going to be important to consider. Right now, he's hearing voices that other people don't hear, and he's currently unhoused. He is street homeless. He's living on the streets. He does have some strengths. In particular, he has a friend that he's very close with, and that friendship means a lot to him. So when we think about APA guidelines and when we think about care, let's keep George in mind, and I'm going to reference him a few times. Okay, on your screen is a high-level overview of the care workflow. And as we think about George, people like George who go through the care workflow and how the APA guidelines apply to this care workflow, hopefully you've been giving some thought to how the County Behavioral Health Agency may design services around those guidelines. So just a couple of thoughts about the key elements. Really, that engagement continues throughout the entire proceedings. It's really essential that we think about engaging early and often and considering how the individual is doing and meeting that person where they're at. We also think about APA guidelines for the county investigation. What are some of the considerations that would go into that? The clinical evaluation, we'll talk about that a bit more. And most importantly, how we think about the care agreement or the care plan and the care graduation. So there, again, are a few links at the bottom of your screen if you'd like to learn more. Let's take a look at the next slide, please. Okay, we're going to talk about some of those factors in detail now. So how is engagement in care aligned with APA? Remember that a key aspect of APA guidelines are about a person-centered approach, about regular support, regular follow-up, ongoing engagement. And so some of the care specifics include engagement with the person throughout the entire process. And so these are opportunities to outreach, to meet with the individual in the community or wherever they're located, wherever they feel most comfortable, and helping to continue to engage to retain people in services connected to things that can support an individual's recovery. As Dr. Avery mentioned earlier, a multidisciplinary wraparound approach is really most effective. And so when we think about things like an FSP, full service partnership, or an ACT team, or just professionals collaborating with each other, ensuring that services are being duplicated or services aren't being missed, and that people are talking to each other so that a social worker knows what a doctor is doing and vice versa, so that together they can support an individual in recovery. Trauma-informed care, we talk about this a lot, really using a trauma-informed lens. So what are some ways that George has been affected? What's been his experience? Are we coming together to think about his early life, perhaps any experiences that he has had living on the street or through a justice-involved lens, to ensure that we're approaching him using a trauma-informed approach? And then I think an important aspect of engagement is including peers and other chosen supports in recovery. Really opportunities for people to have mentorship, coaching, and leadership to guide that recovery process. Let's move on to the next slide, please. Thank you. Okay, I'm going to slow down here a bit. And again, there's a list on your screen, so you can take a look at that in detail later. But let's think about how APA guidelines can be applied to assessment and evaluation for care. This occurs at a couple of touch points, certainly the initial county report, later at the clinical evaluation, and both of those speak to the engagement and the eligibility for care. Beginning with the county report and the clinical evaluation, these really should be thinking about the client's voice and choice. What is the person's goals and preferences? What matters to the individual? Thinking about a trauma that somebody may have experienced or have been exposed to. Certainly considering history of or current substance use or alcohol use, and then other social and cultural and spiritual factors, things that matter to the individual. We think about an assessment, really important that a mental health evaluation is done, and this would include history of and current symptoms, certainly mental health and physical treatment history, what's worked, what hasn't, a mental status evaluation, and then an evaluation for suicidality and a consideration for risk of aggression. All things that should be included. And again, if we go back to George, our example, thinking about how the county report and the clinical evaluation could include or should include his mental status evaluation. How's he doing now? We know that he's hearing voices, his goals and preferences. He'd like his friend to be included in his recovery plan. What's worked, what hasn't. We've said that George has a history of non-adherence, perhaps that he had side effects for the meds that he was prescribed and would do better with other medications. All things to consider, and for understanding George and people like George to develop a personal recovery plan. Next slide, thank you. Let's talk about treatment planning in care, in particular, the care agreement, the care plan, and the graduation plan. APA talks to the importance of a comprehensive plan, a personalized recovery plan. So these are services that are unique to each person. It includes evidence-based services, includes medication, again, very tailored medication to a person, and what kind of supports are afforded to somebody to help support their recovery. The CARE Act, like APA, talks to the person-centered plan, creating a cadre of services that's effective for one person based on their needs, wishes, desires, preferences. Their voice and choice governs what services are ideally included. That could include housing, ideally. Not part of the APA guidelines, but an important consideration for many folks who may be identified for care. And then Dr. Avery talked about collaboration earlier. And so certainly considering that the providers and the individual, along with any chosen family supports or other individuals, are included in the development of the treatment plan. I also do want to quickly mention psychiatric advance directives. Although not required in care, it is included in the language about the care graduation. Psychiatric Advance Directive, sometimes referred to as a PAD in California, is really an opportunity to empower individuals to document what's important to them, what their recovery and their treatment should look like if perhaps they're not in a position to voice that. These are the meds that I might do well on. Here's the healthcare system I'd like to be connected to. Perhaps here's how my rent could be paid, or here's how I'd like to see my pet cared for. And so these are opportunities to put into a package and document and share with folks who would be connected to the individual to ensure that some of those guiding forces are really included in treatment planning. And we do have a link on the screen for more information about PADs or psychiatric directives if you'd like to learn more. We talked earlier, I'm going to slow down a little bit. We talked earlier about really the importance of including families in an individual's care wherever possible, whenever the individual would like to see their family involved is really essential. CARE allows for formal ways that the family can be involved. Initially, a family member can file a petition. A family can also be involved in a formal way, serving as a volunteer supporter. And this is a role that is identified by the individual to ensure that their voice and their choice, their preference needs are identified throughout the care process. There are other ways that families can support the care respondent by becoming educated, by learning more and getting connected to organizations that offer that kind of education. Certainly by advocating on behalf of the member. What are services and supports, medications that the person has benefited from? By offering emotional support throughout the recovery process, including during that journey of uphill battles and of successes. And then whenever possible, and at the respondent's request, to accompany the person to care hearings and to other touch points throughout the process. We do have a family education and support resource guide, which has lots of really valuable information. And so you can find that at our website, care-act.org, for additional information. Dr. Avery, I'm going to turn this to you.
Great. Thanks, Deborah. Well, the CARE Act statute, perhaps not overly surprisingly, includes quite a bit of language about psychiatric medications and guidelines around use of these medications. So how do these medication recommendations fit in here with the CARE Act? So first off, medications may be a component of either the care agreement or a care plan. How does that work? Well, if the respondent agrees to it and the team is able to develop one, that team just develops that care agreement. However, if the respondent is not likely to enter into a care agreement, then the court may direct the county behavioral health agency to conduct a clinical evaluation. And one of the requirements of that clinical evaluation is an analysis of medication recommendations and whether the clinicians feel that the respondent has the capacity to make informed decisions around these medication recommendations. We have an additional training coming up on capacity and informed consent that details this, so I won't go into that too much today. But I might say here that the county behavioral agency may call upon licensed prescriber staff to assist in completing this portion of the evaluation, that portion that's about the analysis of medication recommendations and the capacity to make informed decision around these medications. When appropriate, the respondent and their chosen family and or supporters would participate in these discussions. Then this clinical evaluation and the recommendations within them are then utilized in the creation of a care plan, which is then reviewed by the court. And medically necessary stabilizing medications may be included in the care plan if the respondent lacks ability to give informed consent. Then, during the clinical evaluation hearing, the judge utilizes the clinical evaluation to authorize the county behavioral health prescriber to prescribe these medications to the respondent, even though they lack capacity to give informed consent. In this case, we now refer to these medication recommendations as being court-ordered. Well, how is this different? Well, under normal circumstances, all medications, including antipsychotics, are prescribed only after the person gives informed consent to receive them. This is true of any kind of medication. And informed consent generally means that they receive sufficient information on which to base their consent. That is, they understand their condition, the role of the medication, and the risks of taking and not taking the medication. And they must have the capacity to make a reasoned decision. But when the respondent is not currently able to give informed consent, this can, of course, serve as a barrier to getting that important medication prescribed to the person. Being court-ordered does not mean that the medication will be forcibly administered, and the statute states so explicitly. But it could mean that that medication is now more readily available at the time and the place when the respondent is able and willing to receive it. Even with this court order, however, respondents should still receive appropriate information about the medication, and they should be involved in discussions around these medications. It should be done in the context of a therapeutic relationship between a care provider and the respondent, and modern-day techniques should be used, such as motivational interviewing, problem-solving strategies, shared decision-making, and the like. A side benefit of this court order is providing the clinical team with one more tool to help create a pattern of medication adherence for the benefit of the person's long-term outcomes. Often simply explaining that these medications are an order of the court may help the treatment plan encourage the respondent to accept a medication. In the case of George, the county behavioral health notes in the county behavioral health team notes in the clinical evaluation that long-acting injectable medications might improve adherence. But George is scared of needles, and he's pretty adamant that he's not open to this treatment. Thus, that would have to be forcibly administered if we went down that road, which the CARE Act does not allow. In speaking with George, a psychiatrist found that George was once again open to taking oral medications, and the prescriber notes that in the evaluation, since medications can't be forcibly administered, George may be more likely to adhere to the oral medication as part of his care plan. Let's move to the next slide, and let's talk about the idea of promoting medication adherence, perhaps one of the most important outcomes that we're hoping for in the CARE Act in general. Adherence in a clinical context just means that the person's behavior aligns with the recommendations of treatment, such as a medication treatment or other guidance. In general, the more adherent a person is to their treatment, the more they can expect or look for better outcomes from that treatment. But lack of adherence to medications is extremely common. It's extremely common with every condition being treated and with every medication out there. It's not unusual for people with blood pressure or cholesterol to miss doses every once in a while. So in understanding adherence over time in a person with schizophrenia or also a respondent, it's important to take a very non-judgmental approach to understanding adherence. What we know from research is that the two most common reasons why people lack adherence to medication are, one, they don't think the medication is working, and two, they think the side effects are really problematic. Those are very real concerns that really can't be ignored by the clinician or the patient when trying to come up with a plan for adherence. But then the other side of the coin is, so how do we do that? How do we promote medication adherence? Well, one thing is to make sure that you have careful and thoughtful follow-up plan at appropriate intervals, so that these concerns of, is this medication working and do I have side effects? So those sorts of concerns are addressed on a regular basis. There are also many other techniques that are known in the general literature for helping to improve adherence. Things like building it into your daily routine, pulling in patients' chosen support persons and family members to help them support adherence, and those sorts of things. Another technique for improving adherence, as I mentioned above, is to consider a long-acting injectable medication if the patient chooses that, or if the person has a pattern of periodic difficulties with adherence over time. So as I mentioned above, it's important to advocate for an open and honest discussion with a non-judgmental approach about medication adherence. And we definitely want to avoid the potholes of blaming the individual adherents or stigmatizing the person, but instead adopt an attitude of curiosity, understanding, and problem solving. Okay, so moving on to the last slide in our section here is, again, we want to challenge you to think a little bit here about how do these concepts that we've covered here that Dr. Rose went through around the CARE Act proceedings, how might you operationalize them and apply them to your own daily work? And Deborah, any thoughts you might have about you covered a lot of material, and how would you summarize that into, like, how can we bring that down to where the rubber meets the road in caring for our respondents?
Smart, easy to summarize because there's 3 boxes for us on the screen. So my job has been done, but I'll talk about each one of them very quickly and just give you a few sound bites. I think it's really important that we ensure that when we work with individuals and we evaluate them or do an assessment, that it's really person specific. What's working for somebody? What hasn't worked for somebody? What does that person's upbringing look like? What kind of experiences has George, for example, have had? So really make sure that we understand. You talked about medication, and I think that's a great example. George stopped meds because of the side effects. Are we taking the time to ask those questions? Why did you stop meds? What were the side effects? So we don't need to repeat those kinds of efforts. So taking that time to understand each person and what they look like now, I think is really essential. It's addressed in APA. It's certainly considered in CARE. I think I talk a lot about recovery, not just treatment, but recovery, really understanding that those interventions, aside from medication, are designed to uplift a person, to help someone like George and other folks like him to achieve wellness, to meet their goals, to understand their needs and preferences. And so that can, all of those psychosocial supports, an ACT team, an FSP, job, support and employment, that all of those services really are designed to help an individual thrive. And while I'm not going to talk about psychopharmacology, because I think that you've covered that so well, again, ensuring that meds are designed that are right for a person and for a person to be successful in sticking with medication, and to ideally include whoever the individual is choosing as a part of their recovery team in that discussion about medication side effects and med adherence. I said a lot. That was a big summary. And with that,
okay,
I think
yeah, great. Thanks, Deb. Let me jump back in here then, and let's move to our last slide here then, because we really are wrapping up here with what are the few concepts we want to leave you with here. And so we covered a lot of recommendations, medications, psychosocial interventions, and I hope we conveyed the message that regardless of the intervention, it's very important to take a person-centered approach when you're developing the person's care or treatment plan, that especially with complex conditions such as schizophrenia, think about that care as a wraparound style care that addresses all of the person's critical needs, not just this, not just that, but helping to keep an eye on the prize of the person's long-term recovery and designing the care plan accordingly. And third, antipsychotic medications are typically very important in the treatment of a person with schizophrenia, but that treatment should be approached in a way that's most humane and designed to be to improve the odds of maximal benefits and adherence. And with that, I'd like to hand the microphone back to my colleague, Patricia Doxey, to wrap up the presentation.
Thank you, Dr. Avery and Dr. Rose and Dr. Warburton for kicking us off. Just wanted to reshare the objectives. The goal is that by the end of this training, you'll have an increased ability to be familiar with the APA guidelines and then identify how those can apply in the care process to someone like George, which we discussed, or other care respondents. Some next steps we have for you. So we post all of our trainings and recordings on the CARE Act Resource Center. If you have additional questions or interested in further topics, we encourage you to go there. You can also submit TA requests and get a hold of our email address. We encourage you to go to our training series card, so Understanding Schizophrenia Spectrum Disorders, and we have a few trainings in that series which we thought could be helpful, but there are a number of trainings there that you can view as is helpful. There is no wrong door, so if you want to learn more, if you're curious or want help navigating resources, you can always contact us at our email address there. And many of these resources and links that you saw on the slides as we were going through are linked in the training materials. So go ahead and click open those materials and you can navigate to any additional links. We thank you for your time and we'll talk soon.